Let's begin. So if you have a look at this station, see what comes in your mind. The task says your FY2 in accidental and emergency. Your patient is 85 years of age, was brought to the hospital by her daughter after having a fall. On examination, there are multiple bruises of different ages on her body. She has tenderness on her chest and she has been sent for the X-ray. Please talk to the daughter, Angela, and discuss about the further plan of management with her. And the consent has been taken from the patient to talk to her daughter, right? That's the thing. Now, a lot of question might be there in your mind. Number one is if you see this line in the question, on examination, there are multiple bruises of different ages on her body. When we see this thing, what comes in our mind? Multiple bruises of different ages. So the thing that you should have in your mind is NAI, non-accidental injury, right? So I would say, I'm not saying it is non-accidental injury, but it is one of the biggest reason here for the fall maybe, and it is my topmost differential. Now, the common mistake that most of us might be doing when we have got this kind of station, that we think it is non-accidental injury and we just go for non-accidental injury part, and we forget ruling out other causes of fall. Make sure you don't do that, because if you just go for non-accidental injury, if you just go for abuse part only, what happened? It feels like you are being judgmental. It feels like you already knew the scenario. It feels like you are going with the tunnel vision. So make sure when we do these stations, we have got normal vision. What I mean by that, we will try our best to rule out the medical causes of fall as well. All right. And whenever any elderly patient that comes to us with fall, we do investigate to find out if there are other reasons of fall or not. Yeah. Also, who is coming here with the patient? The daughter. We cannot blame the daughter as well, like if daughter is responsible for it. Yeah. So what you need to do, you need to elaborate a bit more about the social history part as well. Who else is there in the family, right? And what we are doing it in the best interest of the patient. So what I mean, causes of fall. So what you need to do, you need to rule out some causes of falls as well, right? So I would say there are some medical causes of fall, and we have got some non-medical or environmental causes of fall as well. Yeah, obviously we can say there are some lifestyle causes as well, and I would say age is the reason of fall as well. If I put it in this way, it is going to be very easy for you to remember the causes of fall. There are many stations where you need to know the causes of fall. I'll make it very easy for you. So what are the medical causes of fall? I would say the medical causes, if I say in the medical causes, if I say diabetes, can diabetes cause the fall? Yes. When you have got, say, hypoglycemia, you can have fall, isn't it? If I say hypertension, can hypertension be the reason of fall? Yes. I mean, if you are taking many medication for your high blood pressure, isn't it? So there are chances postural hypertension you can have, right? So for diabetes, hypoglycemia, any neuropathy or hypertension, postural hypertension and all, right? Can I say heart problem can be the reason of fall as well? Yes. If you got a heart block, if you got arrhythmias, these can be the causes of fall as well. Can I say eye problems? Yes, there are lots of eye problems can be the reason of fall as well. If you are having blurring of vision, if your vision is not clear, you've got loss of vision, that can be the reason of fall as well. Can I put as ear problem as well? I would say yes. See, ear controls your balance. And if there is any ear problem, specifically we're talking about inner ear, which controls your balance as well. And if there is any problem, then you can have fall as well, right? So I'm not going into detailing. I'm just telling in brief. So diabetes, hypertension, heart problem, eye problem, ear problem can be the reason of fall. Now, if we come to the non-medical causes, environmental causes, what I mean by that, if you're not having enough light in the house, for example, if you're having slippery floors, if you've got loose rugs or carpets, can that be the reason of fall as well? Yes. Lifestyle causes. What is the lifestyle in this? I mean, which lifestyle you think can be the reason? Can I say drinking too much of alcohol or taking drugs and all can be the reason? Yes. And the age. Obviously, if the patient is 85, that is also a reason of fall as well. So what you need to do while you're taking history, don't be judgmental, don't jump into the non-accidental part straight away. What you need to do, you need to rule out some other causes of fall as well. Some of the causes you can rule out in the history, maybe some of the things you can mention in the examination investigation as well. So that is how you need to go about it in these stations. Yeah. What else you are supposed to do? Now, don't forget to take the history. Like if this patient has got any past medical history, sometime the doctor might say, my mom has dementia. She has been having dementia for last 3 years. So you can ask how the dementia has affected her life. That's the main thing. Now, a question comes to me most of the time that if a patient has got dementia, can they give consent? It is written in the station, consent has been taken from the patient to talk to the daughter. When I was talking to the daughter mentioned that my mom has got dementia. That was, it was diagnosed a couple of years ago. So if a person has got dementia, can they give consent? The answer is yes. So what happened in these patients, sometime they have, in the later stages of dementia, sometime what happens is they have the capacity. On the other hand, some other time they may not have the capacity. So it's very, very tricky thing. But whenever you as a doctor, whenever you talk to the patient, you need to assume the patient has got the capacity. So you'll start talking to the patient first. And then you will see if they're talking and you feel like they're competent, obviously they can give consent. And if you feel they are not competent enough, then you will try to involve the family members in the conversation. So, can a patient who's having dementia give consent? Yes, if they are competent at that particular moment. Yeah. Now, what else you need to do? As I said, you need to take social history as well. Social history as well. Who else is there in the family? I know this multiple bruises on the body of different ages. It is giving me a hint. It could be abuse. It could be non-accidental injury. But who is the responsible person? Maybe the daughter. I'm just assuming. I'm not sure. So I need to see who else is there in the family. Maybe there is somebody else who can be the reason of this. Or maybe if I take social history and I found out I've got two children as well. And if you ask me the age of the children, if I say 5 years and 8 years, now, the thing is, if, for example, the daughter, you feel she's responsible for the abuse here, can she abuse two children as well? Yes. So that is why in most of the ethical stations, I would say, taking family history is very important. The social, psychosocial history is very, very important because you are not only managing her, you're not only managing Karen Holmes, the patient who's 85 years of age, you're managing any other person at home who can also be the victim of abuse. So this is very, 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 very important. Yeah. So what are we doing in this? We are asking about the causes of fall. We're taking past medical history for our patient as well. And we're going into brief psychosocial history as well. Right. What happens in these kind of stations, sometimes you will see the daughter, she might be making up some stories like I don't know, I didn't see the fall, and what happened is she was just calling my name. I went into her room and I found that she fall on the radiator. I was worried and I just got her to the hospital. They are gonna make up some stories, and you will see some non-verbal cues here. When somebody has to lie, when somebody is lying, they have to think, because if something has happened, you are very truthful, and something has happened in front of you, you can explain it very easily. But when something has not happened in front of you, when you are lying to somebody, then you have to think a lot of times. You have to think a lot of things. And what happens, you might be talking very fast, you might be looking here and there. So you'll be giving lots of non-verbal cues as well. That is the thing. Now, this patient, I said, has got dementia for last 3 years. So you tell me, uh, if a patient, because when I take history in the past medical history, when I ask the patient, when I ask the daughter, if your mom is going to the GP for the regular follow-up, and she's like, no, she's not. The thing is, if a patient who's having dementia, their problem, if they are not able to go to the GP, what happens? Usually GP comes to their house. GPs, uh, they do home visits as well. GPs, they do home visits as well, right? So the thing is, in the end, you need to bring this point across that there is somebody, like what has happened with the patient, with the mom. It is something unusual because what we found when we examined, there were multiple bruises of different ages. You need to acknowledge those non-verbal cues as well. So sometimes this patient gives the history in the later part of the station that I have got two kids as well. I lost my husband last year, and it is becoming very difficult for me to manage. And sometimes she starts crying as well. And what's going to happen? She will eventually break up and tell you, Doctor, I'm the one. I actually pushed my mom, and I'm really, really sorry. So now, the main thing I always want to stress in this particular scenario is I would say you don't have one patient here. I would say you have got two patients. The thing is, our daughter, in this case, Miss Angela, what she's saying that I'm going through a very tough time. I have to look after my mom who's having dementia. I have to look after my two kids. I lost my husband last year and I have to work full time as well. So sometimes it becomes too much, doctor. And I'm really sorry what I've done. I pushed my mom. So obviously, what she has done was wrong. What she has done was wrong. It is a non-accidental injury. It's an abuse. She has to bear the consequences of it. Now, my question is, do you have any soft corner for Angela or not? What she has done, I'm not justifying. I'm not justifying like when you're going through a tough time in your life, you can do whatever you want and it's justifiable. I'm not justifying that. I'm just trying to ask like, do you have got a soft corner for Angela as well? The thing is, whatever she's going through, it's difficult as well. I mean, she's working full time. She's having two kids to look after. She lost her husband and looking after the mom. So you have to offer some help to her as well. So obviously, for our patient who's 85 years of age, what will be the help? You will be admitting her and doing all the investigations. She has got the bruise, so we'll be sending her for the X-ray as well. What else we can do? We can do the skeletal survey as well, just to see if there is any other injury or not, right? And definitely we will be involving social services as well. See, social services, what they do, if I have to say in one word or one line or one phrase, I would say social services, what they're going to do, they will be doing the safeguarding. So they will look after the safeguarding in the house, right? That's their job, right? Now, what management that you can offer, what help you can offer to Angela? You can mention that I can see you're also going through a tough time and you are not alone. We have got lots of support as well for you. So what are the support options? Number one, you could have gotten the support for your mom. We have got lots of support for elderly patients, for dementia patients. That's one. Number two, as this patient, Angela, she's going through a tough time. So what we need to do, we can involve our talking colleagues as well, our psychotherapists, psychologists, or psychiatrists, so we can put the patient in contact with them as well, right? And definitely the social services will be involved so they can look after the house and see the safeguarding can be done, obviously for the mom and obviously for the two kids at home as well. So that's how you need to manage these kinds of scenarios. I mean, don't think this is an easy one, because in this you have to rule out the causes of fall as well. You need to take history and social history, psychosocial history, and you don't have one patient. I would say you have got two patients: the mom who's 85 years of age and the daughter whom you are talking to. Right. So, for example, in these kind of station, what are the things that will be suggestive of non-accidental injury? What are the things? So, when history doesn't match with the examination. So, what happened is she's saying that I just went into my mom's room and she fell on the radiator and she told me she was having some chest pain and that's why I got her to the hospital. Fine. But when we examined, we found different bruises as well. How she got it? No, she got it because she fell down on the radiator. But the thing is, it's not justifying that, because the bruise that we got, it's for the different ages. So when you see the history, whatever the history the patient or the relative or the daughter, for example, in the previous scenario is giving it to you, if it doesn't match with the examination finding, it means there is something fishy, right? Multiple bruises of different ages, it means something is wrong, non-accidental injury, right? And sometimes you will get this patient, if you're talking to the daughter and she's taking too much of drugs and alcohol, yeah, disability or long-term illness. Sometimes you will see a child, for example, you got a non-accidental injury child. So if you see a child has got long-term illness, for example, the child is say having autism or child is having any other problem, I mean, so it will be very difficult for the parents to look after the kid, and that kid could be the victim of abuse as well. So that happens, right? So if you find any of these risk factors, you have to be very careful. You have to be very careful about non-accidental injury as well. Who are the victims of abuse? Usually extreme of ages, children and elderly patients. Yeah, these are the victims. Obviously, other than that, like mentally disabled females, and anybody can be the victim of abuse as well. But yeah, these patients, you have to be very careful. So in this, how we are talking about, I can see you're anxious. You will see the patient you're talking to, the person you're talking to is a daughter. She's very, 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 very anxious and worried. So you need to acknowledge that. Assess the patient's current condition. That is something you can do. Obviously, you need to rule out other causes of fall. That's very important. Yeah. And don't forget to take psychosocial history. Right. And then obviously you'll bring it up that what we did, we examined and we found there were multiple bruises of different ages. Sometimes this patient says, yes, my mom, she keeps on falling because she's elderly, she's having dementia, so she keeps on falling. And so my question is, why you didn't bring your mom the last time to the hospital when she had a fall? And the thing is, the mom, she's not going to the GP as well for the regular checkups because somebody's having dementia for the last 3 years. Do you think they should be going regularly to the doctors for the checkup as well? Yes, of course. If they are not in a situation to go to the GP can come to your house for home visits as well. Why all these things are not happening? Because there is something fishy. And when you bring this point in a very subtle way, she will open up and give you the information. Again, don't blame her straight away. That is not going to be okay. She will eventually tell you. That's how you need to get it. Yeah. And in the end, obviously, the management would be the x-ray. We do the skeletal survey as well. The medical management, symptomatic management, involve the seniors and involve the social services as well. When you are dealing with the case of a kid, for example, you have got a child who is, say, 10 months of age, and you understood this is non accidental injury. Same thing, like the x-ray, the skeletal survey will be done there as well. But whenever we have got a kid who is a victim of domestic violence or abuse, we do some other investigations as well. Usually we check their eyes as well, we check their ear, and we do a CT scan head as well. Because in children, what can happen? Maybe you have taken the baby like this and you just shake the baby like that. So it can affect the head, can affect the eye and ears as well, right? But in elderly patients, what we do full body examination, we do skeletal survey as well. So in this, the management would be obviously the patient. Patient had what? Patient had the multiple bruises of different ages. She was having pain as well. So the management would be managing the medical condition and obviously the managing this social part of the station as well. So the management is going to be a bit complicated as well. So that's how we will be doing this scenario. Right. Let's have a look at another one as well. This is the very, 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 very important one. Have a look. Here, FY2 in neurology. Yeah. Tracy, she's 78, has been admitted to the hospital because of weight loss. Now, if somebody age 78 losing weight, what it gives to you? I mean, what comes in your mind? Like cancer, that's the first thing that comes in her mind. She has been suffering from dementia in the last 3 years, and she has not been taking any food properly recently. So that is the problem. Okay. All the investigations, including the blood test, the ECG, X-ray, ultrasound, and the CT scan abdomen, they are done, and it is normal. Right. So obviously, when somebody that much of age, like 78, admitted to the hospital and losing weight, our mind says cancer, cancer, cancer. So we need to rule out the worst thing. And that's why we did all these investigations. We did blood tests, urine tests, ultrasound, CT. And the good thing is everything is normal. All right. Patient has been given some fluids and she's able to tolerate a bit now. All right, that's good. It has been decided that invasive and aggressive management is not appropriate. All right, that's good. Palliative care has been decided by the consultant. See, what is palliative care? Palliative care simply means we have to make the patient comfortable. That's it. And the requirement of one patient can be different from the other patient. You cannot generalize palliative care, right? Right. So if I say some patients for palliative care will be putting NG-tube, will be putting a catheter, changing the position so they don't get bed sores, and putting the stockings as well, doing some physiotherapy, joints won't become stiff. Sometimes you have to put some eye drops so the eyes won't become dry as well. So that can be the requirement of one patient. But in some patients, you might not be putting the NG-tube. In some patients, you might not be putting the eye drops as well. So it depends. So palliative care simply means to make the patient comfortable. What is the difference between palliative care and end of life care? See, palliative care is a big umbrella term. Palliative care is a big umbrella term, and end of life care is a part of it. Palliative care you can do for a patient for a month, 2, 3, 4, 5, 6 months as well. End of life care is usually in the end of life, maybe when last 1 week, 10 days, 1 day is left. So we give some medication like morphine, hyoscine bromide, and other things to the patient. So that is your end of life care. So palliative care is a big term, umbrella term. End of life care is a part of it. And palliative care is going to be different for one patient from the other patient, because palliative care simple means to make the patient comfortable. All right. Okay, so she was very weak on admission, but she has been medically managed. Okay, that's fine. Talk to the daughter history and assess the understanding, explain the mother's present health status, and discuss the further plan of management and address the concerns. Patient is not available to talk. That's okay. Consent was taken from the patient to talk to the daughter. That's okay. Then the weight loss is only because of dementia. The weight loss is only because of dementia. Now, the thing is, tell me one thing, in these kind of station, when you go into the cubicle, how are you going to start these station? Are you going to take history to find out the reasons for weight loss? I've seen some candidates doing that, some doctors doing that, that they go in and they take history if the patient has got any other medical conditions and all. And when we ask, why are you taking that history? They're saying to rule out the reasons for weight loss. Should we do that? I would say it is not required. If you do that, you might be wasting the time, because if you see the question is very clearly mentioning that weight loss is because of dementia, and all the investigations, I mean, ultrasound, CT abdomen, everything has been done and it is normal. So what is the point of doing that kind of history? So you don't need to do. So how are you going to start these kind of stations? Just check the understanding of the daughter in terms of dementia, what she understands about dementia. She's asking you one thing, doctor, I just want to know, how is my mom now? She was losing weight. That's why I got her here. How is she now? And what is the status? Then what you need to do, you need to explain a bit more. Like, yes, she was losing weight, and that's why we did lots of investigations. Now, in these kind of station, these counseling ethical station, it is entirely up to you if you want to finish them in 1 minute, or if you're going to finish them in 4 or 5 minutes, or you're going to finish these station in 7 8 minutes. Sometimes I've seen some candidates, they will be saying, yes, we did all the investigation and all the investigations came back normal, so your mom is not having any medical problems, which is the reason of weight loss here. Instead of this, I would recommend you to elaborate a bit more. So what we did, so you're talking to the daughter, say the daughter name is Maria. So Maria, you got your mom to the hospital because she was losing weight. You're absolutely right. So I'm acknowledging her emotions and reflecting it back. And then what you say? So in the hospital, we did lots of investigation to find out what is the reason why she's losing weight. So we did some blood tests to see if there is any infection, any electrolyte imbalance, if there is any heart issues. We did ECG as well. We did the X-ray, we did the ultrasound of her tummy. We did the CT scan, because in this age, she's 78, right? She's having dementia. She's 78. So we are very much worried about some sinister thing that can happen to an elderly patient, like cancer. But fortunately, when we did all the investigation, everything came back normal. So explain a bit more. You can explain it in one line, or you can explain it in 5 6 lines as well. And I would recommend that when you are doing the counseling, say a few lines. Don't give the answer in one word or one line. Say a few lines, then you will see the other person will feel more convinced as well, right? Then the question from her side is, if everything is okay, everything is normal, why she is losing weight? Why she's losing weight? Because of her dementia. That's your explanation, that she forgets to eat. That's the main thing. Now her main concern in this station is, are you gonna put NG tube? Are you gonna put NG tube? Now tell me, in this case, is it a wise idea? Is it a good idea to go for NG tube or not? See, it is a palliative care. Palliative care means to make the patient comfortable. And we said it is gonna be different for different patients. Yeah. So, if you see a few things here, she's able to tolerate a bit now. That's one point. Second is, our team has said no aggressive or invasive treatment for her, right? So, are we gonna put NG tube? The answer is a big no. Why? Number one, uh, She's tolerating oral fluids. Yeah. So why are you giving NG tube to someone who is tolerating it now? Isn't it? Number two, our consultants have decided no aggressive or invasive treatment. So we'll try not to go for NG. And number three, see, the thing is your patient has got dementia. She's not unconscious. What is she having? She is having dementia. So what can happen? She can pull out the tube as well. She can just pull it out. Do you think it's a good idea then? No, she can have the into the whole cavity. So that's why NG is not an option for her. That is the main thing that you need to justify there, right? So just to make sure you explain it in a nice way that she's tolerating the fluids now, and our consultants have decided we don't want to go for any invasive or aggressive treatment. And in these kind of patients, they can pull it out as well. Right. And obviously, the NG tube is not a long term solution, it's a short term solution. And if you're putting something like NG tube, it is going to be a source of infection as well. So there's no point of doing that. Yeah. Now, are we going to keep this patient in the hospital or can we send this patient home? The thing is, there's no point of keeping this patient in the hospital because in the hospital, what can you do? You can do some investigations, right? But investigations are already been done. So if you keep these kind of patient in the hospital for a very long time, what can happen? They'll be prone for infections as well. They'll be prone for infection. So there is no point of keeping these patients in the hospital. So now you will take psychosocial history as well. Who is looking after this patient? Are you able to look after or not? If she is able to look after, that's okay. If she needs our support, we can provide her the support as well, right? So, in terms of dementia, we have got certain services. I'll tell you. The dementia nurses, also known as admiral nurses. So, you can give three options to these kind of patients. So, we can have carer at home. So what is this carer at home? So what can happen? The patient is going to be staying in the home and the dementia nurses or admiral nurses might be coming to your house, will help you in looking after your patients, right? And you're connected with them over the phone as well. For example, any other day you need some help, you need to ask something, you can call them and they'll be able to help you. So that is at home. Another is daycare. So what happens is you can keep your patients in the daytime. You can keep your patient in the centers. Sometimes we call these centers by the name hospice. You might have heard the word hospice. So they've got hospice daycare as well. So in the daytime, you can keep your patients in the care centers so they can get all the physiotherapy and rehabilitation services there. And in the evening, you can bring them back. That is something that you can do. Another one we have got is hospice care home only. So they're small care home, not like big hospital. And only few patients gonna be there, and it's a small place, not much noisy as well, and the patient, they feel like it's my home. They have got that homely feeling as well. So that can also be considered, right? So now what you have to do is you have to take social history. I mean, in these cases, psychosocial history, if she's able to look after the patient or not, and if she needs our help, what kind of help? So hospice at home, hospice daycare, or hospice home itself, right? And the thing is, when you're telling to someone about hospice, you're giving very clear instructions that last few months or weeks left. Hospice, that's what we use. Right. And this is what happens in the advanced stages of dementia, that the patient, they don't know what to eat. They forget eating. That is something happens in advanced stages of dementia. Now, the daughter has got one question about NG, and you have got many justification that NG is not an option. Right, NG is not an option for her. But in the later stages of her life, when she's unconscious or she's not eating at all, we might have to put NG. So I'm not saying that in dementia patient, you can never put NG. I'm not saying that, right? So what I'm trying to say is, in this particular patient, you don't need to put NG because she is tolerating orally. Our consultant has decided no aggressive management, and she's conscious. She can pull it out as well. So that's why you don't need to go for it. Right. So again, you cannot generalize that in dementia patient, we are never gonna put NG tube. It's not like that. So how the daughter is asking you, how can I feed my mom then? The thing is, you have to be very patient with them. They are like kids. These patients are like kids. You have to be very, very, very patient. So what you have to be doing, first of all, cook something which she used to like. If possible, involve her in the cooking as well. You have to give her small, small, frequent meals. Keep her away from the distractions. Keep her away from the distractions. That is very important, right? For example, if you are eating and this TV's television is switched on, so they will be looking at the television. They won't concentrate on eating. So keep them away from distractions as well, right? So this is very, very important. So you have to be very patient. Cook something like liquid or semi-solid food. That would be very important. Cook something they used to like. Involve them in cooking if that's possible. Eat with them. Keep them away from distractions. And the most important thing, take good care of their oral hygiene. Sometimes what happens is that you don't look after the hygiene, and then if the oral hygiene is not good, you don't feel like eating at all. So that is something that you need to promote in these kind of stations, right? So this is something that you need to do in these scenarios, right? Nowadays, what is happening? So they might make changes in the scenario as well. So for example, if I change the scenario saying that in the hospital, all the investigations have been done and everything is normal, and then we did put NG tube for the short duration. And now our team has given her something to drink and she was able to drink. And then we have taken the NG tube out and we're not planning to put it back in. So sometimes this scenario can come in that way as well. So how are you going to managing the questions from the daughter side? You'll simply be saying when you brought her, she was very weak. So what we did put NG tube and then we were able to manage her weight and we gave her some nutrition and then we were feeding her as well. And she started tolerating the liquid and then we took out this NG tube and now she doesn't need it because she's able to tolerate the fluid and our team has decided no aggressive treatment. And these kind of patients, they might pull it out as well. So we have got lots of challenges to face. So at the moment, NG tube is not required. So it depends on the station. If the station comes like this, the way I'm showing it to you, NG tube you don't need to mention because an NG tube is not a required option for the future as well. But sometimes they give in the question that NG tube was given. Patient started feeling okay. And then we took it out. So whatever the task says, please go accordingly. Right? So they keep on making little changes and you will be able to do it accordingly. This station is going to revolve around NG and your answer is no, a big no to NG tube in this particular scenario. Right. Okay, let's have a look at another one as well. Your FY2 in surgery, your patient is Ellie and she's 82, had a wrist fracture on her non-dominant hand after having a fall 3 weeks ago. The cast has been placed. She was given a walking aid to help her to be mobile. Patient has been assessed and is able to use the walking aid. Patient is lucid. Lucid means she's okay, she's fine. Patient is willing to be discharged. So patient wants to go home. All right. All the investigations, including the blood test, the urine test, the ECG, X-ray, ultrasound, are normal. Okay. Amenity, including the physios, occupational therapists, social service nurses, doctors, are satisfied the patient is fit for discharge. Okay. She has been planning to come to the fracture clinic twice per week. Hospital to home service has been arranged to visit this patient twice per week. What is this hospital to home service? So usually this service is given to those who are living alone, elderly patient, those who are living alone. So that's when we do this hospital to home. So what's going to happen in this? Somebody is going to go to the patient's house and going to help the patient in other errands as well. Like which errands? Like for example, buying groceries, paying their unpaid bills, their prescriptions. So this is what is done. And that's what comes under hospital to home service. Right. Some people they think like she has been planned to come to the fracture clinic twice per week, and according to the hospital to home service, she can ask for ambulance and all. No, it's not that. The thing is, if somebody is planned for the any clinical visit, like the fracture clinic visit twice per week, they can always ask for the transport services that can be provided. But this home to hospital or hospital to home service is something different. So what happens in it? So somebody is going to come to your house and going to help you in your buying prescription, groceries, and paying your unpaid bills and also the support. And usually given to those who are living alone. So most probably she's living alone. So her son has got some concern and wants to talk to you regarding the mother. Talk to the son and address the concern. Mother has given the consent. So we have the consent, so there is no problem on that. Now the thing is, son has got only one question. Son has got only one question. Why my mom had this fall? He's saying that my mom is not fit to go home and you are sending my mom home. So I don't feel it's a good decision. When you ask why you think it's not a good decision, because you have not checked her properly. But have you checked her properly? According to you, yes. So what are the causes of fall? That's what I said. The causes of fall you will be needing in every station, in most of the stations. So you can explain. See, there are lots of causes of fall. What are the causes? There are lots of medical causes. And that's why we did the blood test, urine test, ECG, X-ray, ultrasound, and everything came back normal. So we couldn't find any medical reason of fall. But the question from the son will remain the same. Okay, then why did my mom had this fall? Because if you don't know the reason, what can happen? She can fall again as well. So that's why I want you to keep her in the hospital and check her properly. But the thing is, we as a doctor, we have checked her properly already. These patients in the hospital because it is going to be a source of infection. Hospital acquired pneumonia, another infection patient can have. But then son is like, when you don't know the cause of fall, how can you send my mom home? So what you need to do, you need to do counseling here. All the investigations and everything came back normal. Then the son is like, why she had this fall? Thing is, there are lots of non-medical reasons of fall as well, like not having enough light in the house, loose rugs or carpets, right, or slippery floors. And that is why our occupational therapist also visited the house and they have done their arrangements as well, right? So that's how you need to explain. Can this be abuse? The thing is not really, because number one, she's living alone according to the history, and number two is social services are also happy to send this patient home. That's why you need to read the question very carefully, because most of the things are there in the question itself. Because the task says MDT, multidisciplinary team including physiotherapist, occupational therapist, social and nurse, doctors are satisfied the patient is fit for discharge. Right now, the son is not very much convinced. Then explain that we are not going to leave her like that. We have arranged a lot of things. Number one, what we have arranged, she's going to come to the fracture clinic twice per week, and we will see what are the progress in her case. Number two, we have also arranged hospital to home service for her, which is going to be quite helpful as well. So this is what you need to do. I mean, so when you do the counseling part, what you usually do in these counseling, you actually explain what is given to you in the question. So if you use all this information given to you in the question, the patient, the person, the son in this particular case will feel more comfortable in that explanation, right? Now, sometimes the son says, can you talk to my mom and convince her to go in a care home? Why? Because in care home, there will be somebody who can look after my mom all the time. So there will be some support. Is that possible? The thing is, where this patient wants to go, this patient wants to go home. Where the team of doctors, where we want to send this patient home. So the thing is, let her go home, isn't it? So because care home, where this care home subject should come from. I would say the care home should come from the medical team, or this word should come from the patient itself. Right. Because if the medical team feels that it is not safe for this patient to go home, we will look for care home options. Or else if patient bring this point, no, I'm not very comfortable in my house, and then maybe we will be looking for a care home option. But now this patient wants to go home. We medical team, we want to send this patient home. So let the patient go home only. And that's what you explain to this son. But you can tell to this son that you can speak to your mom. You can speak to your mom. If you and your mom both come to a conclusion that care home is the best option, we can look into it. But the thing is, your mom just had a fall. And if we start talking to her about care home straight away, it is going to affect her confidence as well. It is going to affect her confidence as well, which is not an ideal thing. Right? So that's why let her go home now, and we'll be doing this visits home to hospital, hospital to home services, and she'll be coming to the hospital in the fracture clinic twice per week as well, and we'll be getting the updates for her. And that's what we can do. right? So in these cases, what happens is lots of information will be given to you in the question itself. That's the main thing. So what you need to do, you need to read the question carefully. Obviously, the task will be given to you in the cubicle as well. You can have a look at this task again. That's absolutely fine. But make sure try using as much as of information so that the other person will feel more convinced. All right.